mesenteric arterial dissection and mesenteric venous thrombosis. Uh, Regarding mesenteric arterial dissection, I will be discussing about the introduction, etiology, etiology, presentation, diagnosis, classification system, and the treatment modalities, and the surveillance of the patient with mesenteric arterial dissection. Spontaneous isolated arterial dissection within the splanchnic circulation without associated aortic dissection is a rare entity, but it is being reported with increasing frequency. This most likely reflects improved imaging modalities, particularly abdominal computed tomography, and increasing awareness of this condition rather than increasing prevalence. Spontaneous isolated superior mesenteric artery dissection was first reported by Bursfeld in 1947. Coming to the incidence, the superior mesenteric artery is the most common visceral artery affected, followed by the celiac artery. In 1959, Ford reported an incidence of 0.06% of spontaneous isolated superior mesenteric artery dissection from a cohort of 6,666 autopsies. Prior to 2001, only 46 cases of spontaneous isolated mesenteric artery dissections were reported. As of 2016, the number has increased to more than 622 cases. There are even fewer reports of concomitant SysMAD and spontaneous isolated celiac artery dissection. It's most commonly seen in the people of the 5th to 6th decade of life. 30 to 40% of patients with isolated splanchnic dissections presents with hypertension. The majority of cases have been reported in Korea, China, Japan, and suggesting of genetic predisposition. Coming to the etiology, multiple theories on the etiology of isolated splanchnic artery dissections and the cause may vary between different visceral vessels. Proposed etiologies of spontaneous visceral artery dissections include connective tissue diseases like Marfan syndrome, Ehlers-Danlos syndrome, and Loeys disease syndrome, cystic medial necrosis, segmental arterial medullosis, Behçet's disease, and fibromuscular dysplasia. Tobacco use, atherosclerosis, alcohol abuse, obesity, heavy weight lifting, and pregnancies are also being suggested as risk factors for spontaneous isolated visceral artery dissections. Some of theories which have been proposed are Park et al. According to Park et al., the hypodermic forces at the transition point in the majority of the spontaneous isolated superior mesenteric artery dissections originates 1 to 3 centimeter from the SMA ostium. This is the point where the SMA transitions from a fixed retropancreatic position with an acute turn into a mobile mesenteric route. The second one is the elevated shear stress, which the elevated shear stress at this location in the SMA is rather than an underlying connective tissue disease or uncontrolled hypertension. Development of primary hemorrhage in the media due to rupture of vasa vasorum, and chromosome locus 5q1314, which is associated with familial ascending aortic aneurysm and dissections with SysMAD. Coming to the clinical presentation, spontaneous isolated visceral artery dissections has a wide range of presentations, including an incidental finding, an association with bowel ischemia, or aneurysmal formation with or without rupture. Symptomatic CVAD presents with abdominal pain in 90% of cases, which ranges from severe and tearing in the mid-epigastric area with occasional radiation to the back. Other visceral artery dissection symptoms may include nausea, emesis, melena, and diarrhea. Coming to the diagnosis, there is no specific laboratory test for visceral artery dissections. CT angiogram and contrast enhanced CT are now used to diagnose more than 95% of contemporary cases of visceral artery dissections. Less commonly used are duplex ultrasound, DSA, and magnetic resonance imaging, respectively. CT angiogram considered the gold standard for diagnosis of visceral artery dissections. Contrast enhanced CT is capable of identifying dissection flaps, false lumens, re-entry tears, thrombus, intramural hematoma, aneurysm formation, and rupture of splanchnic arteries. When visualization of the dissection itself is limited, increased attenuation of the mesenteric fat may suggest the diagnosis. CT not only identifies the visceral artery dissections, but also demonstrates the characteristics of dissections, such as its origin, length, and concomitant lesions. Coming to the classification system, Sakamoto et al., who studied for 12 patients, has come to the classification system, which has four types. Type 1 is a patent false lumen with both entry and re-entry tears is noted. Type 2 is a cul-de-sac shaped false lumen without re-entry. Type 3 is a thrombosed false lumen with ulcer defect. And type 4 is completely thrombosed false lumen without ulcer. Among these, the type 1 SysMAD were treated successfully with conservative measures, as such as anticoagulation and medical management. In patients with the type 2 SysMAD, the true lumen may be compromised by false lumen compression. So they recommend that these patients be followed very closely for signs of mesenteric ischemia. Type 3 had the highest rate of intervention in contrast to the type 4, which has been managed without any intervention. Yun et al., who studied 32 patients, has proposed the four types of classification. Here, the type 1 is a patent true lumen and a false lumen, revealing entry and re-entry sites. Type 2A is a patent true lumen, but no re-entry of the patent false lumen. Type 2B is patent true lumen, but no re-entry of a thrombosed false lumen. And type 3 is dissection with occlusion of the SMA. As this is relatively simple to follow, and most of the practitioners are following the Yun et al. Classification system. Coming to the Lon et al. Classification, which has studied 20 patients. Here, the type A is dissections at the curve of the superior mesenteric artery and extending proximally to the SMA ostium. Type B dissection limited to the curve of the SMA. Type C extending from the curve of the SMA distally, but not involving the ileocolic or distal ileal artery. Type D extending towards the ileocolic and ileal artery. Coming to the treatment, the patients with who are asymptomatic, the treatment is increasing frequency of the use of CT in evaluating patients with various conditions have led to an increase in the reported incidence of visceral artery dissections who are asymptomatic. However, the role of antiplatelet agents and anticoagulants is not well defined in either asymptomatic or symptomatic patients. Here is a suggested treatment algorithm for patients with the spontaneous superior mesenteric artery dissections. The patients who are asymptomatic is being kept under surveillance with CT angiogram. And if the patient is having hemorrhage and bowel necrosis, the patient will be taken for laparotomy. And if the patient is having pain, abdominal pain without the features of bowel necrosis, a trial period of bowel rest with anticoagulation is given. If these symptoms resolve, the patient will be kept on CTA surveillance. If the patient has persistent pain and the patient is having severe ischemic symptoms, the patient is taken to SMA stenting, and following which the patient will be under surveillance. Surgical treatment. In most patients presenting with intra-abdominal hemorrhage or advanced bowel ischemia, open surgery remains the preferred option. But when bowel is threatened, surgery may include aortovisceral bypass, extra-anatomical bypass, like with the gastroepiploic or hepatic artery inflow for SMA dissection, and intimectomy, fenestration, often combined with vein patch repair. Autogenous graft material, most commonly the greater saphenous vein, has been utilized in most reports. Coming to the endovascular options, thrombolysis, it has rarely been employed in the setting of visceral vessel thromboembolism. There are few reports of its utilization in the setting of visceral artery dissection, usually in combination with stenting. Mixed results have been observed. Coming to the embolization, occasionally patients presents with aneurysm formation or vessel perforation by the false channel as the primary concern. Endovascular coil embolization has been utilized in the setting. Here is a picture which is showing superior mesenteric artery dissections with pseudo-aneurysm formation, which has been treated with coil embolization. Coming to the stenting, the goal of endovascular treatment is elimination of stenosis caused by false lumen encroachment, as well as stabilization of vessel integrity to avoid the late degeneration and aneurysm formation. Persistent pain is considered as indication for intervention in several series, analogous to the treatment of aortic dissection. Mean et al. Suggested that SMA stenosis of more than 80% or a dilatation of more than 2 cm are indications for primary stenting. A disadvantage of endovascular treatment compared to surgery is the inability to inspect the bowel for evidence of ischemia or necrosis. This is a picture showing the superior mesenteric artery dissections, which are successfully treated with endovascular stenting. The left side of the picture above and below shows the superior mesenteric artery dissections, which has been successfully treated with SMA stenting. Coming to the surveillance, CT is a surveillance study of choice. The rationale for surveillance is a potential for visual artery dissection to form a splanchnic aneurysm. Imaging at 1 month post initial visual artery dissection symptoms, followed by every 6 months for the first year, then annual surveillance has been proposed. Coming to the mesenteric venous thrombosis, it is a single entity involving thrombosis within the superior mesenteric vein with or without extension to the portal or the splenic vein. Mesenteric vein thrombosis was recognized as an entity distinct from mesenteric arterial occlusion by Warren and Edward in 1935. Mesenteric venous thrombosis is most commonly encountered in the middle-aged and older adult patients. There is an equal gender distribution. Primary mesenteric vein thrombosis is defined as spontaneous idiopathic thrombosis of mesenteric veins not associated with any other disease or etiological factor. Patients with any conditions known to predispose to mesenteric vein thrombosis are considered to have secondary causes. Approximately 90% of mesenteric vein thrombosis are secondary. Risk factors, several conditions are associated with mesenteric vein thrombosis. These can be divided into 3 main categories like direct injury, local venous congestion or stasis, and thrombophilia. That is a classical of 3 factors identified by VIRCHOW'S, that is vessel wall flow and blood abnormalities. Coming to the direct injury, which can be caused by blunt or penetrating abdominal trauma, post-surgical like post-penectomy, intra-abdominal inflammatory states like pancreatitis and IBD, peritonitis and abdominal abscess. Local venous conditions are stasis conditions like portal hypertension and cirrhosis of liver, CCF, hypersplenism, obesity, increased abdominal pressure, and abdominal compartment syndrome. Some of the thrombophilia states like protein C and protein S deficiency, antithrombin 3 deficiency, polycythemia vera, essential thrombocytosis, 8 cytomegalovirus infection, and extra mesenteric venous thromboembolism. Pathology and manifestations. The degree of interstitial ischemia that develops depends upon the extent of venous thrombosis within the splanchnic venous circulation, whether there is occlusion, or whether there is a adequate collateral flow for the obstruction. Mesenteric vein thrombosis is characterized by a limited segment of intestinal ischemia. The extent of intestinal infection is often limited to the jejunum or the ileum. Edema, swelling, and reddish discoloration of the affected small bowel and its adjacent mesentery. Palpable pulse is a superior mesenteric artery, and its branches differentiate as a superior mesenteric artery occlusion from venous thrombosis. Division of a small part of adjacent mesenteric vessels reveals thrombosis within the veins in case of superior venous thrombosis. Coming to the classification, it can be divided into acute or chronic. Patients with symptoms of less than 4 weeks duration are classified as having the acute mesenteric vein thrombosis. Those with symptoms lasting longer than 4 weeks but without bowel infection are those with clinically insignificant mesenteric vein thrombosis diagnosed incidentally on abdominal imaging are diagnosed to have chronic mesenteric vein thrombosis. Majority of patients have acute mesenteric vein thrombosis. Coming to the clinical examination, the onset of acute mesenteric vein thrombosis is often insidious and diffuse. Abdominal pain may be present for days or 2 weeks. The second most common symptoms is nausea and vomiting, whereas the diarrhea and lower GI bleeding are present in less than 20% of cases. Typically, a middle-aged patient with a personal or a family history of deep venous thrombosis presents with abdominal pain of a few days duration, vomiting and abdominal distension, as well as a clearly raised C-reactive protein. The patient may develop localized peritonitis with progression to transmural intestinal infection with the signs of generalized peritonitis can appear. Coming to the laboratory testings, D-dimer has been reported to be a sensitive but not specific marker. Patients with mesenteric vein thrombosis should be screened for the following inherited disorders like factor V Leiden mutation, prothrombin gene mutation, protein C deficiency, protein S deficiency, and antithrombin 3 deficiency. Patient should be checked for an acquired disorders such as JAK2 mutations. Non-invasive testing like multi-director CT of the abdomen with intravenous contrast injection and imaging in the portal venous phase is the most important available and the accurate diagnostic tool. The CT protocol include biphasic imaging in the arterial and portal phases with 1 mm thin slice and reconstructions in the coronal and sagittal planes. MDCT often demonstrate extensive thrombosis of the portomesenteric system with extension of thrombosis to at least the extrahepatic portal or splenic veins. Intestinal findings are less common and are more subtle. It is a CT angiogram of showing coronal view showing the thrombosis in the extrahepatic portion of the portal vein with ascites and dilated edematous small bowel loops. Invasive testing like exploratory laparoscopy or laparotomy will continue to be necessary diagnostic tool in those patients presenting with peritonitis. Signs of peritonitis are not always associated with the transmural intestinal infarction. In experienced hands, laparoscopy may be preferred method to assess the intestine viability. A major obstacle for viability full visualization and macroscopic evaluation of the small intestines are extensive paralysis with bowel dilatation and prior adhesions. The first line treatment option is coming to the treatment and results. The first line treatment option is conservative with anticoagulation, with fasting and nasogastrial tube decompression, fluid and electrolyte replacement, analgesics, and administration of total parenteral nutrition. The use of antibiotics directed towards intestinal flora in cases of advanced mesenteric vein thrombosis and with the risk of sepsis. A few patients will undergo laparotomy and bowel resection at 3 different time points. First is admission due to the late presentation or diagnosis. After some weeks due to the failure of anticoagulation therapy to reverse the condition. In other group of patients after some months due to the late bowel stricture. Extensive mesenteric vein thrombosis can be successfully treated with recombinant tissue plasminogen activator with a dose of approximately 100 microgram for 48 hours. Endovascular treatment in combination with heparin infusion with or without bowel resection in those few patients who do not respond satisfactorily to heparin infusion alone. Coming to the medical treatment, immediate full anticoagulation with continuous infusion of unfractionated heparin is used in surgical as well as non-surgical cases. Activated partial thermoplasty in time of 50 to 70 seconds monitored at 4-hour intervals. In the early phase, unfractionated heparin is preferred as it has anti-inflammatory effect and if the patient deteriorates, if the chances that the patient is going to taken for surgery, it can be reversed by protamine sulfate. Every patient should initially be closely observed with repeated abdominal evaluations and body temperature readings, as well as daily CRP and leukocyte measurements. In the absence of recovery with rising CRP values, or in the case of any clinical deterioration, repeat CT examination with intravenous contrast is indicated. CT scan shows changes such as extension of venous thrombosis and can evaluate the severity of ischemic bowel lesions. When gastrointestinal function has normalized, LMWH or oral vitamin K antagonist or new direct oral anticoagulations are advocated. Most thrombosis shows either no change or regression after a short period of vitamin K antagonist treatment. Lifelong treatment with VK is recommended owing to the high recurrence rate of mesenteric vein thrombosis, which is up to 36% without anticoagulation. A long-term treatment with LMWH is reserved for patients with liver dysfunction or other conditions in which oral vitamin K antagonist treatment is contraindicated. Most patients can be treated conservatively if they are diagnosed in a timely manner. The duration of anticoagulation therapy must be carefully balanced against risk factors for bleeding. An alternative medical option is the use of fixed dose directly oral acting anticoagulation. The advantages include the fewer interactions and less need of frequent monitoring. The disadvantages include the lack of antagonist to factor 10A inhibitors and lack of specific safety data in patients with mesenteric vein thrombosis. The effects of another dopa, that is dabigatran, a thrombin inhibitor, can instantly be reversed with idarucizumab. The overall 30-day survival in contemporary series was 80%, and the estimated 5-year survival for the 51 patients was 70% in medically treated patients. Prognosis of patients with MVT after hospital discharge seems to be highly associated with underlying disease, and the cancer patients have the poorest survival. Gastrointestinal bleeding, late small bowel perforation, and intestinal stricture have been described as specific gastrointestinal complications. Most patients are treated successfully with medical treatment only, but a small proportion of patients deteriorated during the medical treatment. In those situations, clinical practice in some centers during the last decade has been to initiate endovascular treatment. Coming to the endovascular treatment, the various options include percutaneous transjugular intrahepatic photosystemic shunting with the mechanical aspiration thrombectomy and direct thrombolysis, percutaneous transhepatic mechanical thrombectomy, percutaneous transhepatic thrombolysis, thrombolysis via the SMA, thrombolysis via an operatively placed mesenteric vein catheter. Rapid thrombus removal or dissolution can be achieved through these techniques, especially after tips and stent placement to create a low pressure runoff. Mechanical thrombectomy is performed using a variety of thrombectomy devices and is most effective in cases of acute rather than chronic thrombus. Before considering thrombolysis, checking for relative and absolute contraindications of thrombolysis must be seen. Local direct thrombolysis into the photosystemic circulation through the transjugular or transhepatic route is useful for clearing residual clots and restoring venous flow. Indirect thrombolytic therapy via the SMA is less effective and more time consuming, may require longer infusion times and higher doses of thrombolytic. And it is can you hear me, sir? Hello?
Yeah, Chandan, go on.
Yes, sir. Yes, sir. Balloon a local direct thrombolysis into the mesenteric circulation through the transjugular or transhepatic route is useful for clearing residual clots and restoring venous flow. Indirect thrombolytic therapy via the SMA is less effective and more time consuming, may require longer infusion times and higher doses of thrombolytic agent, and it is also associated with an increased bleeding risk. Initial intimal trauma that can produce rethrombosis is the risk factor associated with angioplasties. Balloon angioplasty is an alternative technique of clot fragmentation in cases of refractory thrombus and fixed venous stenosis. Aspiration thrombectomy is performed with a stiff, large diameter and angled catheter connected to a lure lock syringe to create a vacuum effect. A potential drawback of thrombectomy and angioplasty is intimal trauma which can promote rethrombosis. Local thrombolysis was associated with significant bleeding complication in 60% of patients. Patients should be anticoagulated with unfractionated heparin following endovascular treatment, and the bowel should be arrested. Vitamin K antagonist or a direct oral anticoagulation replaces heparin when gastrointestinal function is normalized. Patency of portal system after tips can be evaluated by follow-up Doppler ultrasound at 1 and 3 months, and then again at the 6 months to check the portal system and the stent function. Clearance of thrombus can be evaluated with CT angiogram. Coming to the surgical treatment, the indications for surgery are peritonitis, severe gastrointestinal bleeding, small bowel perforation, and intestinal stricture. When an emergency laparotomy must be performed, endovascular treatment with thrombolysis is contraindicated. If there are signs of extensive intestinal ischemia, one possible strategy may be surgery. Bowel resection should be performed in cases of frank transferintestinal necrosis, uncertain bowel viability, or a severe ischemic bowel lesion. Primary bowel anastomosis after resection is recommended. There is a straightforward treatment in the typical patient in whom a short segment of small bowel is affected. Immediately after surgery, heparin infusion is administered. The patient should be on bowel rest and receive a total parenteral nutrition for a few days until the return of gastrointestinal function. All patients should then receive anticoagulation with either LMWH or vitamin K antagonist. Lifelong treatment should be considered for most patients owing to the high recurrence rate and then often a fatal outcome in case of recurrence. Repeat CT scan after 6 months of anticoagulation therapy may be helpful in determining the duration of treatment if lifelong treatment is not being considered. Bowel resection should be performed in cases of frank transmural intestinal necrosis, uncertain bowel viability, or severe ischemic bowel lesion. Primary bowel anastomosis after resection is recommended. The straightforward treatment in the typical patient in whom a short segment of a small bowel is affected. The survival rate after bowel resection is around 80%. The most common complications following surgery are pneumonia, wound infection, renal failure, sepsis, and gastrointestinal bleeding. The occurrence of short bowel syndrome after bowel dissection for mesenteric thrombosis is rare. It is a schematic representation of treatment for a suspected case of mesenteric vein thrombosis. Initially, a patient will be evaluated with three-phased CT with intravenous contrast. If it is known to be a mesenteric vein thrombosis, immediate anticoagulation is recommended. If there is a clinical stability, screening for thrombophilia and a lifelong anticoagulation for most patients is recommended. If the anticoagulation in the selected patients with reversible causes, the anticoagulation can be continued for 6 months. In cases of clinical deterioration, to consider the endovascular treatment, otherwise to look for laparotomy with the resection of non-viable bowel. Thank you, sir.